Hello, I'm Jim Carroll, the CEO of the diaTribe Foundation, and it's my pleasure to welcome you to our 14th online Musings. Today's discussion is definitely on a hot topic, as you can barely open your newsfeed or turn on your TV without hearing about the opportunities for unprecedented weight loss and better diabetes management made possible by these new and sometimes not so new medications. But with all the excitement comes some mixed messages related to body image, what defines healthy weight for an individual, and the stigma and the feelings of blame and shame that very often come with having diabetes and obesity. But before we get started, I'd like to give a huge thank you to our sponsors for our 2023 Musing series, who make these online opportunities for us to learn free to everyone. And starting with our very generous platinum sponsor, AstraZeneca. The folks at AstraZeneca have developed therapies that not only improve A1C and time in range, but also significantly reduce the risk and the consequences of diabetes complications. I'd also like to thank our gold sponsors, Lilly, Novo Nordisk, Abbott, Dexcom, Sanofi, and Vertex. They're great. And thank you to our silver sponsors, Genentech and Ionis. All of these companies are responsible for the development of groundbreaking technologies and therapies that allow people with diabetes to live healthier lives. In addition, they provide the essential support that allows diaTribe to pursue our mission to improve the lives of people with diabetes through education and advocacy. It's now my pleasure to introduce the moderator of today's panel, Matthew Garza, diaTribe Senior Manager who's working on our Stigma program. Matt joined diaTribe in 2020 as part of our 2-year associate program, following his graduation from the Johns Hopkins University with a degree in biomedical engineering. In his second year, he was a managing editor of the diaTribe Learn publication, and he's since stayed on to launch our anti-diabetes stigma program called Destigmatize. Matthew has an amazing passion for understanding how stigma impacts health outcomes for marginalized groups such as LGBTQ population and those living with chronic conditions, including diabetes and obesity. So I leave you in very good hands with today's moderator, Matthew Garza. Matt?
Thank you so much, Jim, for that super kind introduction. I'm honored to be able to moderate this panel on a very important topic that affects so many people today with diabetes and obesity. Now, the question at the heart of today's panel is this: how do people with diabetes navigate a world where on one hand, you are being told that you can be healthy at any weight, but on the other hand, you need to lose weight to be healthier? And of course, these competing messages are being thrown at you at the same time that you're trying to focus on the million other considerations that come with simply trying to live your life with diabetes. From managing your glucose levels, to monitoring your risks for diabetes-related complications, to taking care of your mental health, and everything in between. So where do we begin with such a complex topic? Now, healthcare professionals are continuing to stress the importance of weight loss or weight management as being key to living a long and healthy life with type 2 diabetes. And while for so many years the recommendations were quite limited to diet and exercise, this incorrectly simplifies several really complicated chronic conditions. Today, all you have to do is look at the news, social media, or pop culture to see countless stories about this new wave of glucose-lowering diabetes medications like Mounjaro and Ozempic and others that can lead to dramatic weight loss. But most healthcare professionals and researchers acknowledge that even these new treatments aren't going to be a silver bullet, adding more complexity to the issue. And finally, we are learning so much more about the value of individualized recommendations and the fact that many people can and do have healthy, fulfilling lives regardless of their weight or body size. However, stigma, shame, and blame permeates just about every single conversation we have around diabetes and obesity and the medications that we use to treat these conditions. So if you're anything like me, trying to make sense of all of this is probably making your head spin a little bit, but that's okay because I am extremely excited to dive into these topics for what I know is going to be a jam-packed discussion with our amazing panelists. So without any further ado, let me introduce the 4 incredible women who are going to help us explore this topic today. First, I want to start by introducing Dr. Claire Lee, who is the Executive Medical Director at Lilly Diabetes. Prior to joining Lilly, Claire was an assistant professor at the Johns Hopkins University School of Medicine's Division of Endocrinology, with a clinical and research focus on type 2 diabetes and obesity. Claire earned her medical degree from the State University of New York at Stony Brook and completed her endocrinology fellowship at Johns Hopkins. She continues to actively care for people living with type 2 diabetes alongside her work at Lilly. Welcome, Claire. Next up is Dr. Rebecca Pearl, who is a clinical psychologist and stigma researcher, and who directs the Body Image and Stigma Lab at the University of Florida College of Public Health and Health Professions. Her work, which is supported by funding from the National Institute of Health, investigates those health impacts of and interventions to reduce weight, appearance, and health-related stigma. She completed her PhD at Yale University and her postdoctoral fellowship at the University of Pennsylvania. Hello, Rebecca. Next, I get to introduce Michelle Tedder. Michelle is a nurse educator, health equity strategist, obesity advocate, and she is living with type 2 diabetes and obesity. She serves as senior program manager of the Black Women's Health Imperative, the only national nonprofit dedicated to the health of Black women and girls. And there, she led the creation of the Diabetes Self-Management Support Program curriculum. Michelle holds bachelor's and master's degrees in nursing from the University of Pittsburgh and Indiana University of Pennsylvania. Welcome, Michelle. I'm so excited to have you with us here today, so that way you can share your journey with our audience. And last, but certainly not least, as a diabetes specialist with Clinica La Esperanza in Albuquerque, Virginia Valentine manages a wide variety of challenges in diabetes in a primary care group that serves an extremely culturally diverse community. She is board certified in advanced diabetes management, is a certified diabetes care and education specialist, and has been recognized with numerous awards throughout her career. Virginia is a longtime friend and contributor to diaTribe's work, including participation in our D-Series events, which led to the launch of the Destigmatized program, which I am so grateful to be a part of. Virginia earned her Master of Science in Nursing from the University of Oklahoma College of Nursing, and she has lived well with type 2 diabetes for more than 43 years. Thank you so much for being here today, Virginia, and thank you all for being on this panel today. So without further ado, I'm going to dive right in and get started because we have a jam-packed session with so many questions. And my first one is going to be for Claire. Claire, what are people's options today when it comes to treating type 2 diabetes? And I'm curious if you could tell us a little bit about the effects of these new treatments on people's diabetes and weight management.
Yes, thank you, Matthew. First of all, thank you so much for having me and amongst these distinguished panelists. It's my pleasure to be here today. So regarding your question about type 2 and different options, what an exciting time to be in this field as provider and a family member of someone with diabetes. We have a lot more effective tools now than when I started being interested in this space. I want to take a moment to just recognize, more than 10 years ago when I got interested in type 2 and obesity, it was really looking at the dramatic impact of bariatric surgery and what that had on diabetes and other metabolic disorders when you help someone to lose substantial amounts of body weight. And those were sort of the light bulb went off in my head when I saw those types of changes that my patients were undergoing. And back then, there was nothing to really get us to anywhere close to that level of body weight reductions between lifestyle intervention and pharmacotherapy. And here we are, it is an exciting era because we have, there's an advent of highly effective treatments that are in part taking the wisdom that perhaps surgery has taught us, that there's something about the hormones in the gut that really play an important role, turns out. Perhaps not surprisingly, if you think about the evolution, right? Upon meal, some gut hormones called incretins signal to the body that food is here, let's make more insulin, tells the brain, the stomach is full, so you should be no longer hungry. So there are these components that we are able to harness for therapeutic purpose. So that leads me to the one of the newer tools in the field that you were getting at, Matthew. So we're thinking about GLP-1 agonists like semaglutide, and then you add another hormone to the GLP-1 called GIP, which is another incretin hormone, and that would be your Mounjaro.
Thank you so much, Claire. Now, Virginia, I'm going to come to you with this next question, which is basically that the American Diabetes Association updated its standards of care this year and put a slightly greater emphasis on weight loss, and suggesting that people with type 2 diabetes should aim for somewhere around 15% of weight loss to help with their overall diabetes management. This is a pretty lofty goal. So I was curious if you could tell us a little bit about what might be behind this change and what that means for people with diabetes.
Well, I think it's really clear that 15% of your body weight loss would have a dramatic effect on your diabetes control. But the bad news is that's really, really hard to do. And fortunately, with the help of the GLP-1 antagonists, we have the ability to get there. And in my personal story, I've had diabetes for over 43 years, and was put on insulin back then. So I gained a lot of weight. And in 2002, I was at the airport, DFW. I had an epiphany that I needed to lose weight, which you would think I would already have known that, having been a diabetes educator for a long time. And so I started working really hard on it. After a year of trying to eat less and walk more, I had lost 10 pounds because losing weight sucks. And then I got in a clinical trial for Simlin, which I lost about 15 or 18 pounds. And the day Byetta came on the market, I started it. For most of you who are older than I am, younger than I am, that's the first of the GLP-1 drugs that came on the market. And I started really losing weight. And it was not rapid. Over 5.5 years, though, I lost 100 pounds. Wow. I know. I was amazed. And that's when I started really understanding stigma. First, I already knew that as a person who weighed 250 pounds, I was more or less invisible, that people don't see you, they don't talk to you, they don't treat you like you're even present in the room. When I got thinner, I realized that a whole nother level of stigma, because now I'm included in conversations that I did not know were being held. And that is sitting around talking with other diabetes educators and hearing them talk about other people in the room who were overweight or obese, or talking about their patients. And that was a real shock in and of itself. And so it's been my lifelong mission to address stigma and to get rid of the shame and the blame. And so that's why it's been my thrill to work with you, Matthew, and diaTribe, who are now trying to take stigma to a whole new level. And it's something, but I do want to mention, I do love the new drugs. I work in an underserved population. And so more than half of them are on Medicaid. Medicaid hates your drugs, Dr. Lee. It's so sad. So I spend a lot of time every day fighting for the ability for my patients to have access to the really good stuff, as I refer to it. And so that's been a real issue. But I will tell you, the one thing I have learned, and that people are now starting to figure out, and I tell my patients, we're going to start on whichever one of the GLP-1 drugs. I said, you will lose weight. You have to work with it, you know, but it will help you. It'll lower your glucose. It's got cardiovascular improvement. It's got all these good things. And when you stop the drug, those good things stop. You're going to probably need to plan on staying on the medication for life. And they look at me, I said, see, because that's my secret. People are like, wow, it's impressive that you didn't regain weight. I never stopped. I've been on all the GLP-1s. I've been on a 43-year one rat trial. So far, the rat lives, but I've never stopped one of the GLP-1s, whichever was the one of the day. So
that's such an amazing story, Virginia, and thank you. Your perspective as having lived with diabetes and as an educator and as someone who's in the actual clinic working with people who live with diabetes and obesity is so important. And already you've touched on so many exciting topics that I know we're going to dive into. And so I want to give Michelle the space to also share a little bit about her story. You know, all of these advancements, and especially these new GLP-1 agonists and the GLP and GIP drugs especially, are so exciting. And they're just offering so many benefits to people who live with diabetes and with obesity. And so I'm curious, Michelle, as someone who has dealt with type 2 diabetes and obesity throughout your life, could you tell us a little bit about your own health journey? And specifically, I'd love to hear about your diabetes diagnosis and how your treatment plan evolved over time to where it is today.
Yes, thank you, Matthew. Those are great questions. And I can resonate with many of the things that Virginia just shared, being someone who lives with obesity, and thank goodness diabetes very well controlled. But I was first diagnosed in 2001 with type 2. And it was a pretty stressful season in my life. I always think that it was the stress that I was dealing with at that point, as well as my weight and a number of other factors that we know contribute to some health changes that really kind of, tip the scales, if you will, no pun intended, with the type 2 diabetes. And at that time, there was, I've never been on insulin, but the oral treatments, I remember my doctor placing me on glipizide, and it caused terrible hypoglycemia, like at night for me. And I remember walking into her office going, I'm not taking this. And so she was, trying to convince me that I said, you're going to have to find something else. So, a couple of different trials of different things. And finally, we ended up landing on metformin. Mm-hmm. And so for anybody who's ever taken metformin, who's watching, that it has terrible GI side effects until you figure out that you really need to take it after you've had breakfast and lunch, because that whatever's going on in your digestive tract, it will absorb the medication. So we went through that. And then when Januvia came out, that ended up being one of the drugs that was a maintenance drug for me. But the one thing that I found was very, very, very helpful on my health journey while I was managing type 2 was I started exercising. And I started out just walking. Like I said, I promised myself that I would walk for at least 10 to 15 minutes every day. And then that turned into 20, and then that turned into 30. And I have to say that it was that and the combination of Januvia that got my numbers into what were acceptable ranges at that point. But fast forward to 2017, I had weight loss surgery and had the gastric sleeve. And that was a game changer. And my type 2 went into remission right after surgery. And I got a lot of other wonderful benefits with that decision. And my blood pressure medication was cut in half. I no longer have to take any of the cholesterol medications. I can sit on the floor and not be afraid to get up and play with my grandson. And I lost and kept off 25% of my pre-surgery weight. And I'm into my, I guess, 6th year. So I have been very fortunate to have, good care providers and who partnered with me to create an individualized treatment plan that has worked for me. And I always like to emphasize that in my advocacy work is that, I don't think that it's either or when you're trying to treat diabetes as well as obesity. There's a toolbox of treatments that you really need to be able to have access to. And I, like Virginia, spend a lot of my time in front of policymakers, sharing my story, my lived experience, but also, my knowledge as a nurse and someone who walks the walk. And one of my maintenance drugs for the obesity now is the Ozempic. And so that is that and exercise. And I continue to participate, in lifestyle change and, making sure that my stress levels are what they're supposed to be and all of the things that you really need to be able to access and do in order to live a healthy lifestyle as we're talking about.
Absolutely. You took the words right out of my mouth, because I was going to say, just hearing, and in my conversations with both you and with Virginia, what I've learned so much is that it's all about what tools we have in the toolbox to live a healthy life and to manage both of these chronic conditions. And I want to turn back to Claire real quick with a question about specifically two of these newer tools. And so we have these two medications in particular that have been getting a lot of attention lately, and we've been alluding to this: Ozempic and Mounjaro, also known as semaglutide and tirzepatide for those who work in the science and the research space. And these have been really instrumental in kind of shifting the way that we're thinking about diabetes and obesity treatment. Now, just over a year ago, when tirzepatide, also Mounjaro, was approved for the treatment of type 2 diabetes, around that time, we were also getting all of this really great data and the results from the clinical trials that we were looking at for that drug. So I'm wondering if you could tell us a little bit about some of the newer and the latest clinical trials for Mounjaro and what they might mean for people with diabetes and with obesity. And even if this new data might indicate that Mounjaro would also be approved in the future as a treatment for obesity for people with diabetes or even people without diabetes.
Yeah, thank you, Matthew. So you're right. The Mounjaro is the brand name for tirzepatide, and it was approved approximately about a year ago. And leading to that approval were several trials that show the efficacy and safety profile of this drug. And that program for phase 3 was called SURPASS. Now, more recently, there are a few additional studies that's been disclosed. For example, SURPASS 6 looked at adults living with type 2 diabetes. All enrolled participants were on basal insulin, and we were comparing tirzepatide against adding 3 doses of mealtime insulin. And we were encouraged to see that overall, tirzepatide was superior to 3 times mealtime insulin in terms of A1C reductions of 2.6% in tirzepatide versus 1.3% in terms of really 4 injections of insulin, right? Basal plus 3 times mealtime insulin. And so that was one of the more recent trials. We have a few ongoing trials that will answer important questions with regard to those who are at higher cardiovascular risk and what are the outcomes over more of an extended step treatment with tirzepatide. So stay tuned for that. And so to wrap up to make a transition to the other program, phase 3 trials for chronic weight management, which is currently under investigation. Like you said, Matthew, we're seeking for approval of that indication, but stay tuned. We have disclosed trial results between last year and now. We have SURMOUNT 1, 2, 3, and 4. Mainly 1 and 2 have been disclosed in more of a full length, and 3 and 4 have been top line. Just to summarize quickly, these trials, except for SURMOUNT 2, included participants living with overweight or obesity without type 2 diabetes. SURMOUNT 2, it was an exception where it included patients with type 2 as well. But all in all, it was we were encouraged to see results of weight reductions that were substantial. And I have to pull my little cheat sheet right here. In terms of SURMOUNT body weight reductions, the mean weight reductions with the highest dose for SURMOUNT 1 was 22.5%. And other longer trials were showing even greater weight reductions when you follow them up for additional 14 to 18 weeks. So altogether, 88 weeks, you're seeing close to 26% body reduction. And, kind of tying back to what Michelle was alluding to about her journey with the surgery, I can truly say, combined with my experience of treating patients in the past with, who had undergone bariatric surgery, this truly is a new era where you can reach that level of efficacy with the, obesity medication.
Wow. I don't blame you for having a cheat sheet, because I feel like the results from these trials are so impressive and there's so many of them. You probably need to write it all down in order to remember everything. And it is really incredible that these new drugs are showing us this level of weight management and weight loss that is rivaling or even surpassing what bariatric surgery was able to do in the past. And I think it's so incredible to see that, especially when we think about how in the past, all we really had access to was insulin or metformin, maybe bariatric surgery for those cases where people really needed some extra help. And today now we have all of these new tools to help people manage their condition. But something that we have noticed here at diaTribe is that people with diabetes and obesity have been receiving a lot of mixed messages. And I alluded to this at the very beginning of the panel, which is just that on one hand, we're being told how important it is to lose weight in order to improve your physical health, better manage your diabetes, and prevent complications. But people are also being told that there's a need to prioritize body positivity, have a positive self-image, and that it's really and truly possible to be healthy at any size. And we know that when people adhere to those ideals, it's going to improve self-esteem, it's going to improve mental and emotional health, self-efficacy, and more. And so now I would love to hear from Dr. Rebecca Pearl. Rebecca, I have a feeling that these mixed messages are probably having an impact on people with diabetes and obesity. And I'm curious if you could speak to some of those psychological effects that having to hear these opposing ideas might be having on people.
Absolutely. It's a really important question, and I'm really excited to contribute to this conversation and to be here with all the other panelists and appreciate hearing everyone's stories and perspectives. So as a researcher, I would say this is an empirical question that really hasn't been studied in research. So I can speak to it from, my perspective as a psychologist who has spent a lot of time talking with and interviewing research participants and patients who are interested in losing weight and also recognize that they may have internalized some of these negative messages about body image and about weight stigma, which I think we can also talk about in a bit. And, I've really heard folks grapple with these competing messages, and psychologically, I've heard expressed a lot of guilt about maybe wanting to lose weight, while at the same time having these values around not judging other people because of their weight, not wanting to judge themselves because of their weight, wanting to be able to have a positive, self-image and body image. And I think often the way these messages are presented, as you suggested, is, that they're two competing ideas, that you can either lose weight or you can be body positive. And so what I, have seen and what I think is that they don't have to be conflicting messages, that people can achieve both at the same time, that people can fully accept themselves and their bodies just as they are, and at the same time want to change their health behaviors, potentially want to lose weight, especially if it's having a health impact on them. And that these don't have to be competing ideas. But I think given all the messages we're bombarded with, where these are kind of pitted against each other, that either you're in one camp or another, I think that can really be stressful for individuals who are grappling with this. It can lead to additional shame or guilt, on top of the shame that they're already feeling because of their weight. So I think it's not very helpful to, add to that feeling of shoulds, that you should feel this way or you should feel that way. And we really need to move past that and get to a place where we can embrace that either or both of those approaches might be best for any given individual.
Absolutely. And yeah, trying to avoid what that kind of self-judgment that like I should be doing this or someone should be doing this is so kind of like vital to really understanding this problem, and then finding ways to make health decisions moving forward that benefit you and make sure that you're able to live a happy life and have a good quality of life. Now, Claire, I'm wondering from your perspective as an endocrinologist, so you're focused a little bit more on that, diabetes management, reducing the risk of diabetes complications. I'm wondering if you could tell us a little bit more about, beyond just being skinnier, why are people with diabetes being told to lose weight? And especially in some of these, like you said, newer trials that are looking at, for example, the cardiovascular benefits of these new drugs. What are some of these later studies looking at, and what are these kind of other health benefits of weight loss?
Yes, thanks, Matthew. Obesity management is an important aspect or treatment goals for anyone living with type 2 diabetes, because there's a direct correlation in terms of both diseases worsening the risk of cardiovascular disease. For example, obesity, just like diabetes, is a chronic progressive disease that has been shown to be independently linked with elevated cardiovascular risk, and especially among those living with type 2 and obesity, both conditions. It's it's further exacerbating their risks of not only cardiovascular disease, but also risks of complications that we work so hard to prevent. So to me, it's no brainer that we have to focus, not just on glycemic control, but also on weight management, with the end goal in mind that you're here to improve the patient's health. And for that reason, these two are sort of intertwined in terms of how they can be related in terms of pathophysiology, right? One leads to, for example, obesity, increased risk for type 2 diabetes, but also treating obesity in those living with type 2 can also dramatically improve their metabolic profile and glycemic control as well. So for that reason, it's very important to look at obesity management as an important therapeutic goal.
Absolutely. And I think there's this other idea that is just kind of, as Rebecca said, not necessarily a competing idea, but, what do we do when we separate weight from the equation of health? What if we are trying to achieve health regardless of body size, regardless of weight? And Rebecca, I'm curious, what are the positive impacts of this more body positive mindset? And how can it ultimately, maybe even lead ultimately to better weight management?
Yeah, well, I'll first couch this into there needs to be more research in this area. Yep. Because especially relative to other, areas of research around weight, research on positive body image is relatively new, and there's less research that's been done on this. But, we can define body positivity or positive body image in a lot of different ways. One way it's been defined is appreciation for one's body, or one aspect of positive body image is really kind of valuing, appreciating one's body, especially for what it can do, really beyond aesthetics or what it looks like. And we do know from some emerging research that having this kind of positive body image, body appreciation is linked to less disordered eating behaviors, to less depression and anxiety, to better self-esteem and overall better mood. Which makes sense at face value, right? If you like your body, you like yourself, you're going to feel better. You're going to have lower risk for engaging in harmful behaviors that are detrimental to one's body and to one's overall psychological and physical well-being. Another aspect of body image that there's been more research on is negative body image. And negative body image is not necessarily the opposite of positive body image, even though you might think that at face value. So, negative body image is really disliking one's body. And then, from there, you could move to weight neutrality or body neutrality, just kind of accepting your body as is. And then, another element is actually really loving and fully appreciating one's body. So the positive end of the spectrum, there's a lot less research on, but there's been decades and decades of research on negative body image, or when people really have a dislike, dissatisfaction for their bodies. And that we know is linked to, a really high risk factor for eating disorders and disordered eating, as well as unhealthy weight control behaviors more broadly. And all of these behaviors undermine weight management. These are things like, fasting, purging behaviors, over exercising. These are not things that actually promote obesity management or, weight loss in a healthy, effective way. And in addition, have really significant serious risks for a person's health and mortality. So, even separate from whether or not someone's losing weight, the kind of relationship that they have with their body can have a really big impact on their mental and physical health, and are certainly not helpful for facilitating effective and healthy weight management.
Absolutely. And even though we didn't really name it there, my guess is that stigma, whether it's that internalized stigma or external stigma that someone might be experiencing for having obesity or having diabetes, is probably playing a role. So, Michelle, I was wondering if you could maybe tell us about any of your own personal experiences with diabetes or weight stigma. Have you ever encountered prejudice or stigmatizing comments? And how have these messages, maybe of blaming or shaming somebody for having diabetes, affected you?
I have so many things I could say, but we don't have enough time. We don't have enough time. So yes, I mean, throughout my life, even as a little kid, I have experienced a lot of stigma, bias, judgment, that kind of thing around my weight, because I do live in a larger body. And, I had to accept a long time ago that no matter what, I'm going to be someone who lives in a larger body. And so as we were talking about body positivity, if I can kind of loop some of that in, and I'm going to circle back around to what you asked me. I don't know if people know the history of the body positivity movement, but it came out of the modeling industry because there was a lot of discriminatory practices and behaviors for models who were considered acceptable, right? Not only from size, but the color of their skin, those kind of things. And so the people impacted by it began to advocate for themselves within the modeling fashion industry that people accept themselves exactly as they are, no matter the color of your skin, no matter your size, that everyone has beauty and that it should not be limited to people who are a size 5 or below. Okay, so we need to understand that that is where the conversation came from. It was an advocacy movement around accepting people as they are. And so, in my advocacy work, that is a huge, huge part of what I lead with because, and I'm always coming, I told you, Matthew, in our private conversations that I'm always coming for the BMI because the BMI is a structural, right? Discriminatory tool, as far as I'm concerned, that does not tell the whole picture of a person's health. And so you ask if I've experienced being discriminated against or stigmatized around obesity or diabetes. Well, specifically, the stigma that I have experienced has been from healthcare providers and structural systems in place within the healthcare system that does not look at the totality of humans, whether you are in a large body or not. So I said all that because I recently had a situation, when you lose a lot of weight, you have a lot of skin. And so I have had some skin removal surgery and was recently scheduled to have a breast reduction. I did everything that I'm supposed to do. I have maintained 25% of my weight loss, which is what every bariatric surgeon hopes that people will do. Not only lose it, but keep it off. I've done that. My cholesterol is within normal limits. Mm-hmm. My hemoglobin A1C is within normal limits. Mm-hmm. I have a clean bill of health in terms of being healthy for surgery, according to my weight management team and my PCP. Yep. They would not allow my plastic surgeon to do my surgery. This is just August of this year at the surgery center because my BMI was 0.75 over the state mandated limit for what you can do at the surgery center. So what that meant was my date had to be rescheduled, and it couldn't be rescheduled at the surgery center. It had to be scheduled at the hospital because of the BMI, I was a risk. Check all of the fact that all of my labs and everything lined up with someone who's healthy to be able to have this surgery. And it also meant that I needed to pay, which I'm paying out of pocket, an additional $2,500. So these are structural things that are in place that we have got to speak about as patients. And I feel like I'm a bit of a unicorn. I think Virginia is too, in that we're both healthcare providers and we experience a chronic disease, and we know what these types of systems and processes that are in place that put people at a disadvantage to get comprehensive care. So I don't know, that was a lot. I hope that I answered your question, but I don't come to any panels without bringing that to the forefront because that's, if we really want to change the game and make sure that people have access to comprehensive care for their treatment and they're looked at as individuals from a comprehensive standpoint, we will stop and we will fight to dismantle these types of things that create the space for the implicit bias, both internally and externally.
Absolutely. Thank you, Michelle. The first time you told me that story, it frustrated me. This time it frustrated me again, because I think so often too, we think about stigma as a very kind of like a one-on-one conversation type of thing, that somebody makes a comment or an unfunny remark, and that's kind of an experience that people have. But it's also structural, and it's the way that it prevents people from accessing services for their health and just for their quality of life. So thank you so much for telling us about that. I wanted to quickly jump over to Virginia because you as well are, in this kind of dual space. And so I'm wondering, from your perspective as, a healthcare professional, as someone who is in the clinic as well, do you feel that, similar to what Michelle is saying, that these HCPs, that healthcare professionals, are contributing to the stigma? And what can healthcare professionals do if they recognize that stigma is impacting the people that they're seeing in their practice?
Oh, absolutely. And the patients will tell me about, the providers in our practice who abuse them, and treat them as a lesser person because of their weight, their size, and also, even their A1C. It's not easy for everybody, especially when a lot of times the insurance companies won't help us. In our area, I don't know if this is all over the country, but if a patient's A1C is greater than 10, they won't be approved for using a GLP-1 or an SGLT2. I'm like, yeah, that would just suck, wouldn't it, to have their A1C drop by 3 points? And it just is so frustrating to me, making up these crazy rules. And there's so many, when Michelle, you were talking about structural, and it made me think about anytime you walk in a room, you look around, you see the chairs that are not going to be wide enough. When you get on an airplane, do you know that an airplane seat, an average coach seat, is 17 inches wide? I don't know about you guys, but I look down and it's more than 17, and then there's the seat belts, and, for the person who has to ask for a seatbelt extender, it's a humiliating thing. You can buy them on Amazon. And I've told patients that, I said, listen, just go on Amazon and buy a seatbelt extender of your own. Take it with you. You don't have to ask. And then in the clinic, the gowns, in ours, they're paper gowns, but they're not big enough for, and so that's another thing that's difficult to live with. So I see that, and I'll tell you, as a person who's older, at 75, it's getting more and more difficult to like go upstairs. And it's always amazing to me how many places blatantly ignore the Americans with Disabilities Act. But I'm seeing it more and more. I'm being aware of it. Yeah, Michelle, I know that I've been there. And when a healthcare professional says things like, well, if you would just lose some weight, whatever they say after that doesn't matter, because it's going to be something that's going to make me mad.
Absolutely. It is. It's so frustrating. And thank you. So many of those are really great, I feel like, recommendations, not only for people to kind of have and to know that they can advocate for themselves in these spaces, but also I hope that there's some healthcare professionals on the call today who are also learning about what an impact they might be having on the people with diabetes or the people with obesity that they see, and trying to be more mindful about that. I want to switch topics just a little bit to go back to some of those newer drugs that I was talking about earlier. And I think that one of the main things that's contributing to the mixed messages that we've been talking about and the stigma that accompanies them, as well as diabetes stigma more generally, is the media. And especially right now, you can't turn on the television without seeing either an advertisement or a news segment or some celebrity talking about Ozempic or Mounjaro. And the problem is that sometimes I don't know if this discussion that they're having is always helpful or informative. Instead, oftentimes what's accompanying this media hype is judgment, blame, and misinformation. So, Rebecca, I'm curious if you feel like this media hype is helping or harming people with diabetes and obesity, because I feel like on one hand, it's really great that we're raising awareness about these medications, but I've also seen the conversation hyper-focus on weight loss, and there's a lot of stigma creeping in. So I'm wondering what your thoughts are on all of this.
Yeah, and again, I'd love to see folks study this to really get a sense at the population level of the shift of attitudes or how this is affecting people. But I agree, I've seen a lot of stigma showing up in these conversations. So one area of stigma is in how people view use of medications, and this has been going on with surgery too for a long time. Where I've often heard from patients or people, who don't know much about it, of feeling like, well, this is an easy way out, that really people should be able to control their weight or their diabetes with a diet and exercise alone, and, taking a pill, that's just an easy way of avoiding the hard work of diet and exercise. And this is an incredibly misguided notion, because first of all, no matter what someone is doing to try to manage their weight, whether it's with medication or with surgery, that always comes with lifestyle changes. And I think often, people don't realize that this isn't just I take a pill every day and that's it, that there's, counseling that goes along with it, that people are always encouraged and trying to make healthy food choices and to be physically active. And regardless of a person's weight, that's always the goal, right? For people to engage in healthy behaviors. But people also don't usually realize all of the really, challenging biological barriers to losing weight through just diet and exercise alone, not to mention all the environmental and structural barriers that people have to, engaging in healthy behaviors. So as Matthew and others have said earlier, these medications and surgeries are an additional tool in people's toolboxes. But there can be a lot of blame and self-blame among patients of feeling like, well, I failed and that's why I have to take this medication. So there really needs to be counter messaging to go against that narrative and really understand that this is not people's fault. It's not some kind of moral failing or failing in them, as personal characters, that these are real biological and environmental challenges, like with any health condition, with any disease, that, require comprehensive treatment and lifelong management in order to improve health. I think another area of stigma is just so much focus on weight loss from an appearance perspective and looking thin, And that is not the purpose of obesity treatment. That is not the purpose of diabetes treatment or any of these medications. So, really trying to shift that emphasis on appearance, on this thin ideal, and move it more toward what are the health benefits of taking these medications? How is this improving people's lives and quality of life, that people can, have more energy to run around with their kids or grandkids, not the body focused or even facial appearance focused conversations that we've had. And the last thing that just I've observed is, some of the celebrity gossip that gets roped into this. I just really don't think that's helpful. I think it kind of undermines the seriousness of these health conditions and the true reasons why people need these medications, why people benefit from these medications. So that's from my perspective. But again, I would love to be doing some research on this to, really better understand its effects.
Absolutely. And I hope if there's any marketing professionals or communications professionals or PR people in the room today, that you're taking some good notes on some of these suggestions about just what type of messaging we should be having. And so I want to ask my next question to Claire. What do you think that the pharmaceutical industry can do and maybe is already doing in its media and outreach campaigns around these drugs to make sure that we are getting this accurate information out there about the opportunities that these new medications provide without contributing to the stigma that people might experience?
Yeah, first I want to just echo a lot of great comments Dr. Pearl has made, that as a citizen, I find it dizzying myself, the amount of media hypes that are around. Some of them are helpful, but not all of them. Mm-hmm. So from the pharmaceutical industry standpoint, we are very mindful of, providing accurate information, and whenever possible, participating in the conversations with the external partners to really elevate the understanding around the disease space. We believe we have a role and perhaps responsibilities with these highly effective therapeutics that we, contribute in that regard to really have accurate information out there, and also help, as a field together, increase our awareness and understanding of why, type 2 diabetes is a chronic disease, and obesity is also a chronic progressive disease.
Absolutely. Yeah, it's definitely going beyond just, the accurate information about each medication, but also about the diseases that they're intended to treat, and all of the different tools and treatments that are available to people. Now, we are coming to a close at the end of our discussion, and I want to make sure that we have plenty of time for some audience Q&A. So I want to take this next moment to see what advice some of our panelists have for people living with diabetes and obesity to better empower them during their visits with healthcare professionals. And I'd love if there's also some advice for healthcare providers so that they can have more productive and less stigmatizing conversations with the people with diabetes and obesity that they see in their practice. So I'm going to start with Virginia, and I'm curious if you could speak just a little bit more to some of the strategies that healthcare professionals can use to discuss these new treatment options without contributing to stigma. And especially just because you really have the pleasure of getting to work with a very diverse community, if there's any kind of culturally specific recommendations that you have, or how to, tailor your messaging to the people that you're actually seeing in the clinic.
Thank you for asking, Matthew. One of my favorite recommendations whenever I'm talking to groups of healthcare professionals is to tell them to come out of the closet and be authentic about the fact that they too have diabetes. Your patients will appreciate that so much. If I'm talking to a group of patients and I say, I too have diabetes, you literally see people lean forward. And being authentic is the most valuable thing you can do for people. And that would be my short answer. One quick thing, though, I want Dr. Lee to address is when people say, this is just a diet and exercise issue, in their studies, of Mounjaro and other GLP-1s, whenever they'll do a study on people who don't have diabetes and look at weight loss, and the people who do have diabetes, and the people with diabetes can never lose, even on the same medication, same conditions, they don't lose weight as well, which to me just proves that this is, not a character flaw. This is not gonna, it's not something, it's just that having diabetes affects your ability to lose weight, even with the wonderful drugs that we now have available.
Absolutely.
Yeah, agree
Claire,
with you.
do you have, yeah.
It's a pretty common observation, not in the obesity therapeutic space, but also in bariatric surgery, that it's been repeatedly observed that folks with type 2 tend to lose less. And we don't exactly know why, whether there's increased elements of insulin resistance, but I think more research is needed to better understand why.
Absolutely. I want to keep us moving, and just so that way we have enough time for audience Q&A. So my next one is for Michelle. Now, you've shared already one of these experiences that has been really awful in an interaction with the healthcare system. So I'm curious to know what has helped you the most when it comes to achieving the health goals you want to reach, advocating for yourself, and if you have any recommendations for people with diabetes or obesity who might be feeling isolated, shamed, or blamed for simply living with their conditions.
I would say that the foundation that has been a game changer is learning to love and care for myself exactly as I am. And that takes some work. It takes some therapy. But that has to be where you start, because as we've been talking about for the last hour, all of the messaging that you get, the internalized stigma, the internalized even hate for yourself, and really not appreciating who you are and who you're created to be, really ends up being very self-sabotaging. So I would say the very foundation of what you need to do if you're living with any chronic disease, whether it be diabetes, whether it be obesity, is to be able to learn to look yourself in the mirror and say, you're worthy, you're worth it, and that you're going to do whatever you can do to love yourself. And part of loving yourself is advocating for yourself, being willing to demand that people treat you the way that you deserve to be treated. There's a saying in my community that says sometimes you have to teach people how to treat you. And so that is true in personal relationships, professional relationships, your healthcare provider relationships, is that if you don't understand something, you deserve an explanation. You deserve to be seen as an individual, and you deserve to be a partner in your own healthcare, right? Not someone telling you what should be for you, but someone partnering with you. And I would say to other healthcare providers, the best thing you can do for the people that you work with is approach people with curiosity, not judgment. But I want to see you. One of the biggest things that was a game changer in my journey was I had a PCP, was prior to me having weight loss surgery. She saw me. Wow. She saw what I was doing. She saw how I was struggling. And she was the person who was able to sit down, because I had a lot of self-blame and a lot of guilt about it. I'm like, my internal gremlins, as I call them, would tell me, you're a healthcare provider. You ought to be able to do this. Like, you're working out, you're doing this. What's wrong with you? I mean, I really struggled. And she was able to sit down and just really silence that negativity and really help me understand that I was dealing with a disease and that it was bigger than me. So I think that those are the key elements of what has been and continues to be the foundation for my success at keeping the weight off and staying healthy.
Absolutely. Rebecca, I was wondering if you had anything to follow up, just as, your perspective as a psychologist and someone who works within Stigma. Is there any quick recommendations or advice that you can give to people on having the ability to reduce some of that self-stigma or self-blame that they have?
Yeah, well, I mean, that was so well said by Michelle and by Virginia earlier. So, there's no quick fix to this, especially these messages are often so ingrained and we're exposed to them since we're young children. But there are some behavioral strategies that I and others have used and tested, that can help people to get to that place of self-acceptance and reducing the negative self-talk. So one strategy that, folks who themselves have diabetes or obesity or just anyone can use is to start to really challenge some of the stereotypes or assumptions that are based around weight or diabetes, to push back on the idea that someone is a quote unquote failure when they are having trouble controlling their diabetes or quote unquote controlling their weight. And, an exercise someone can do is to really think like, well, let's say I think I'm lazy. Let me actually look at myself. Let me look at my accomplishments. Let me look at my roles in my family and my job and my relationships. As a whole person, am I really a lazy person, or am I really, a failure as a person? And to try to shift the focus from just being so much about weight defining a person's worth and characteristics, and instead try to kind of shrink the weight of weight, right, in a person's kind of self-image and self-concept, and gain more perspective that, you are more than just your weight, you are more than your diabetes, that everybody is a whole person, a complex person with lots of, individual strengths and characteristics and the reason that your loved ones and that your friends spend time with you and adore you is not because of appearance, because of these kind of superficial things. It's all these really important internal qualities. But I would echo to what Michelle said of, getting involved in advocacy is a great way to feel empowered, and finding other people who get it. Yep. Right? Being around other people so that you don't feel so alone, because this is such a common experience and no one needs to feel alone in these experiences.
Absolutely. And I think it's so important to remember that, because sometimes we can be our own harshest critic, and sometimes you just need to take a step back and ground yourself in reality that so many of us are doing everything that we can to better our health, and that's enough. So my last question, and then I promise we're going to go to the audience Q&A. Claire, what is your greatest hope for this new generation of glucose-lowering medications? They've already been shown to really help optimize care, to help people with weight management, with diabetes management. What is possible with this new, group of medications, and what potential impact can they have on these twin global epidemics of diabetes and obesity?
Thanks for that question, Matthew. My hope is that these medications will be additional really helpful tools for our patients, so they can once and for all truly move the needle on that glycemic control side, and additionally look to benefit with regard to weight control, and combined get closer to their goals in terms of achieving health. And at the same time, being able to perhaps be enjoying a simpler regimen, sort of what Michelle alluded to, in terms of as you gain on the health goals, will you be able to reduce the amounts of antihypertensives perhaps, or other medications? Those types of aspects are remaining to be seen, but it certainly gives us hope that these medications, as they achieve higher efficacies without complicating our patients' lives, say weekly dosing and other regimens, I think are giving us hopes that we're going to be able to do this perhaps in a not so complicated way.
Absolutely. Well, thank you all so much. This has been such a fruitful conversation, and I'm excited to get to some of our questions from the audience. So actually, Claire, I'm going to come back to you with our first one. We have a question from Tamara, and I think that we have actually had a couple questions around this topic, so I'm super interested to hear what you have to say. What about people with type 1 diabetes and obesity? We've been talking very stringently about type 2 diabetes, but there's a lot of people with type 1 who also have obesity or overweight and are looking for answers. So is there any hope or help for them?
Yeah, this topic has been coming up more and more. Unfortunately, the epidemic of obesity has been affecting the type 1 population as well. As we all know, with type 1 diabetes, you do need insulin. You need to stay on insulin, let me emphasize. But certainly the concern remains about, being able to achieve a healthier body weight in order to, again, overall achieve health. So there's a handful of studies that have looked at this, but not in a very systematic manner. But I think I remain cautiously optimistic that sometime in the future, perhaps we'll have a little more guidance around what the role of GLP-1, perhaps GIP-GLP-1s in this space. But again, right now we have pretty much no evidence to guide us. So mind you, this is more of an exploratory sort of thought, suggestions. But I think certainly it's an unmet need in the field. So I think more studies need to be done in this space.
Absolutely. Thank you for that honest answer. And I just want to hopefully be an advocate for the type 1 community. If there are people who are researchers and healthcare professionals and those working in pharma, that we make sure that we are not leaving the type 1 community behind whenever we are talking about these newer obesity treatments, because we want to make sure that we are creating opportunities for everyone to better manage their health. My next question is going to be for Michelle. And Virginia, if you have any follow-up after Michelle goes, I'd love to hear from you as well. But I'm curious, for these medications, I am assuming that you have to be on them for your whole weight loss journey. What has that experience been like for you? Is that true? And is that what you've been seeing?
So part of my weight maintenance includes Ozempic. And so, I think what you have to understand as a patient is like the mechanism of the medication and why you probably need to prepare to be on it for the long haul. As Virginia was indicating earlier in her journey. And, there's messaging that happens between the brain and the gut. And oftentimes when you struggle with obesity, the full communication pattern does not work the way that it's supposed to. And so the GLP-1s really help to make you feel full for a longer period of time. It slows down the metabolism of the food, so it's, in your gut a little bit longer. And that's one of the key things that you really need in order to maintain your weight or to continue to lose weight, is that you got that the signal, the communication between the gut and the brain, really, you've got to figure out how to get that regulated. Yep. And I can honestly tell you, mine started with the weight loss surgeries when you have 3/4 of your stomach removed, like things change. So, and that's a good thing. But I can honestly tell you that prior to that, I didn't know full before it was too late. Like I would have, eaten past full. So that's a long way to say yes. I think from my personal experience and what I hear other folks living with obesity say is that you probably need to be in it for the long haul.
Yep. I want to make sure that we have time. There's 2 really good questions that I want to get to. So my next one is going to be for Virginia. It's from Lois, George, and many others have been asking some similar questions. What about the cost of these medications? What needs to happen to increase access, especially for those people on Medicare and Medicaid?
I wish I knew. Medicare is actually covering, this depends on your insurance, your drug plan. And it's, I feel the payers are struggling with incorporating these benefits because they are incredibly expensive, like over $1,000 a month if you just were to pay cash. So it's a real difficult thing for all of us pay for the providers. And then our Medicaid plans have a big issue with all this, because they don't want to spend most of their budget just on pharmaceuticals, especially when when they really believe in their heart that it's a character flaw. And so then so that aggravates them to pay this money for these medications. And Michelle and I will tell you, well, in our clinical trial of 2 rats, Michelle and me, we've discovered that you have to stay on it for the rest of your life. That's not something that's been studied, but other than our own little personal trial, right, Michelle?
Yes, I would agree. The other thing, if I can add to that question, for those of you who are listening, whether you are a healthcare provider, whether you are a lay person, what you're somebody living with obesity, you got a cousin, a friend, a mother, or somebody, a dog, I don't know. You really have to make sure that you bring this issue up and this need to your state, your local and national policymakers.
Yep.
I sit in a lot of rooms with policymakers, and you believe it or not, a lot of them don't even, especially at the local level, who really have the power to influence the national, they don't really know the ins and outs of this particular space. And so I really emphasize to people, if your insurance company or your job does not provide the coverage that you need in order to address and treat your obesity or diabetes with a full spectrum, write letters, schedule meetings to go talk to your state representatives, your local, do all of that, because those are the things that will ultimately move the needle. Because like I said, when I talk about structural policies in place, that is part of the issue, is that we have policies in place that are not friendly to getting the comprehensive toolbox of these treatments. So it's really important that you advocate.
Absolutely. Make your voice heard, even if you're just an ally in this fight. It's so important. Claire, do you have anything to add to this access question, given your role?
Yeah, thank you. And, access is such an important topic. It takes a village for us to improve access for our patients. So we are working hard to partner in that regard, to be a part of the solution. And at the same time, we also have a few sources, such as lilypricinginfo.com, that shows a list price, but also shows you the price that will affect you depending on your insurance situation. And there are also phone numbers such as 1-800-LILY-RX that'll provide you with some more information regarding special programs that could save you on the cost aspect. So couple aspects to this topic.
Thank you, Claire. Now, I think this is going to be our last question, and it's going to be for Rebecca from Kate. And after this, then we'll go ahead and close it up. So I'll ask Rebecca if you could keep it as brief as possible, although I know it's going to be a complex question. So can you talk a little bit more about the disordered eating that comes from the fact that these medications are causing people to eat a little bit less, right? They're feeling full more. And then there's that psychological component that you're receiving all of these compliments and you're starting to be treated differently because of how you look with this weight loss. And then there's all these intense fears about, regaining that weight or having obesity again. I'm just curious if you could speak to any of these kind of issues.
Yeah, this is a really important question. And I'll say as far as like the new medication trials, I'm not sure of what's been studied in terms of eating disorders, so that might be a better question for Claire. But I know historically in obesity treatment studies, there's very little evidence that these treatments actually cause eating disorders. There's always going to be a very small proportion of people who might have vulnerability to engaging in unhealthy eating behaviors, even in a medically managed program. But the vast majority of people do not develop eating disorders in response to these treatments. That being said, there really needs to be screening before treatment is provided for these risk factors for eating disorders, so that we're not inappropriately prescribing treatments or encouraging behaviors for folks who have pre-existing disordered eating behaviors or have a history of eating disorders. So there needs to be a lot of care and consideration and patient-centered care, so that we're not recommending weight loss or these kinds of behaviors or treatments to folks who really might be vulnerable. The other piece of it, the kind of social reaction to people losing weight, that is absolutely a bigger societal issue and part of the need to really shift the narrative away from appearance and praising weight loss from this perspective of appearance, and instead, praising the efforts that people are putting in to be healthy, to change their health habits. So that I think is also something that's really important, and something that providers might, certainly want to be aware of. And if they see distress from their patients, if they hear their patients talking about this, to be supportive or to refer their patients to counseling, to professionals who can help them navigate these issues.
Absolutely. Thank you, Rebecca. That's so important, and such an important consideration in all of this, right? It's so easy to focus in on all of the really important benefits, but it's also important to keep in mind where there's still risks involved. So thank you to all of you. Unfortunately, that is all the time that we have for audience Q&A. So I'd like to thank all 4 of my amazing panelists today for their contributions to this really important discussion. I'd like to thank all of our sponsors for making diaTribe's free Musings events possible. And I want to thank everyone who's in the audience for taking the time to participate in this event.